I'd like to give a bit of background on myself to give context for the information I'm going to share. So I was diagnosed 24 years ago. My educational background is in law and communications, and my career ended with my diagnosis of lupus. But then I became a volunteer with the Lupus Society and became really interested in the education and understanding the disease, learning more and writing and talking about what I learned about it. So I consider me as your journalist today. I'm not a scientist, I don't have a science background, but I have been to several of these international congresses and tried to learn as much as I can and bring the information back to you. I apologize that I don't have slides. We just returned from Australia on Sunday, and so I have a lot of notes, and I'm going to have to refer to my notes. Some of the information is very technical, and I don't want to give you any wrong information, so I will be reading more than I would like to do, but I'd like the information to be accurate for you. In these international congresses, doctors from other countries will give parameters for diagnosis or treatment or research that might be different than the practice here. And it's a little dry for me to list all of the doctors' names and all of the research centers, but if I talk about something that is of interest to you, please see me afterwards because I have the notes and I can tell you where a specific fact comes from. So I'm not going to give you all the sources as I speak, but I'm happy to sit with you later on today and give you the detail if there's something that would help you and you'd like to take that information to your doctor. So that's the parameters to start. It was wonderful to go to Melbourne. It's a beautiful, modern, large city. The Melbourne conference was attended by delegates from every continent in the world, from 54 countries. There were 859 delegates. 74 of those were patients, and the rest were medical doctors, rheumatologists, dermatologists, or scientists. So a lot of PhD researchers who are working to understand the genetics of lupus and find a solution. Patients were many from Australia, but there were also patients from the Philippines, Indonesia, Africa, Europe, US, Caribbean. The almost 800 scientific delegates were focused on finding a better treatment for lupus. Hundreds of research studies were presented. One of the studies presented was our research, which is at the back, the poster. So the Lupus Society of Alberta partnered with the University of Waterloo and the University of Calgary to conduct research on the economics of lupus. That is how we as patients are affected because we don't earn as much money. If we work, perhaps we work part-time or we work at a lesser level than we did before our diagnosis. Additional costs of childcare and healthcare that may not be covered. So our research involved the interview of 28 people who are living with lupus and assessing the financial cost to us. That research was presented to the Canadian Rheumatology Association in February, and then I presented it in Melbourne to say that our quality of life is affected in this way. So that was quite an exciting project for the Lupus Society of Alberta to be able to present that research there. And we now are participating in a grant application with the University of Calgary to start to get a grant to do more research on this subject, the economic impact. And so if that grant is received, then there may be an opportunity for you to participate in that and tell your story about how lupus has affected you economically. With respect to the conference, I'm first going to talk about the research progress. And that's really, what we want to do. What we want to see is something new and exciting for us. Much of the research presented in Melbourne came from the Asia-Pacific Lupus Collaboration, which includes Australia, New Zealand, East Asia, and South Asia. Researchers were from China, Japan, India, Taiwan, Hong Kong, Singapore, Indonesia, Korea, Malaysia, and Australia, and they presented current research on diagnosis and treatment. Some of the research was coordinated with ongoing research in the US, Canada, and Europe. And so in Canada, we have Canios research, we have the SLIC research, which Michelle Petrie coordinates, and Europe works on that as well. But the Asia Pacific has a different approach, and so there was, because of the conference being in Melbourne, there was a lot of research from their group. Some of their research coordinates with North America, but a lot of it takes a different approach. The Asia approach takes different kinds of, they take a different look sometimes. So some of the Chinese research would be on diagnostics and treatment in methods that are not yet accepted in North America, and yet they were recognized by the international committee at the conference as being interesting. So the benefit of going to that kind of conference is that you can see other countries who take an approach that wouldn't yet be accepted in North America. As an example, a Chinese doctor has refined stem cell treatment. Now, stem cell is only used for people who have lupus nephritis and are at end-stage kidney disease. So it wouldn't be used if there is inadequate treatment, but if the treatments that we have are not effective and somebody's in kidney failure, they may, in some countries, seek stem cell treatment. A Chinese doctor has refined the technique for that using umbilical cords, and he claims to have an 84% survival after 5 years. So these people at end-stage disease, this is extending their life. And so he claims to have a different technique for stem cell and to have more success than occurs in other centers. At the conference, European and North Americans were also well represented by clinicians, researchers, and Big Pharma. Big Pharma has scientists who are rheumatologists and PhD, and they work with the pharmaceuticals to develop these clinical trials. And so they have spent millions trying to develop a successful treatment. Hasn't really worked yet, but they are still working, and there were several of those representatives who were meeting with the scientists, the clinicians, and the university scientists to design clinical trials that might be more successful. Numbers are important in the research for a cure. Europe has 500,000 lupus patients. I think in Canada our number is about 30,000. Lupus Foundation of America claims that the U.S. has 1.5 million people who have some form of lupus. That's about 1 in 274 people, which seems to me a much different number than we would think. In Canada, we think for Caucasians the number might be 1 in 1,000 patients, and for Asians, Africans, Indigenous, we think the number is about 1 in 500,000, but the U.S. claims a higher frequency. There are other countries now in this Asia-Pacific group that aren't normally represented at these world congresses in the numbers they are. And so China claims they have 1 million people with lupus. China has a population of 1.3 billion, which is 4 times the United States. So probably the number of patients with lupus in China is much higher, and more people will be diagnosed. There are no good numbers for the amount of people in India with lupus, but India was well represented in the new research at the Congress, and they have a population of 1.25 billion. So as more people get to their rheumatologists and are diagnosed, I think that we are going to see big numbers coming out of there, and they are very interested in the research. Indonesia claims to have the 3rd highest frequency of lupus behind the United States and Australia, and they have a population of 250 million. So there is a push there for new treatments, and they were presenting research. Scientists from these Asian regions are working hard to prove new treatments, and the population numbers are compelling. U.S. Big Pharma is now conducting or planning clinical trials in China, Korea, and Japan. So they recognize the potential there with the numbers of people and often compliant populations where people are happy to enroll in clinical trials and participate and make the contribution to research. Since the 1950s, new treatment protocols, new ways to use medications have improved survival with massive reduction in death. But it was stated at the conference for the last 20 years, treatment has flatlined. So for about 30 years, people were dying in more alarming rates from lupus at earlier ages, and the doctors learned how to use the treatments properly to improve survival. Survival has improved a lot, but over the last 20 years, it hasn't changed much, and our quality of life is not that much better. We live longer, but we don't necessarily live as well as we'd like to live. The conference chair, Dr. Eric Morand of Melbourne, told patients that science has failed to innovate in powerful ways, and that they must do better to reduce death and damage from the disease. Damage results from high disease activity, chemotherapy, and steroid higher than 4.6 milligrams daily. So they know that if you can reduce your daily steroids to 4.6 milligrams or less, you will have less long-term damage and live longer. The disease process was described this way, and Dr. Keeling alluded to this, that viruses turn on interferon. There's a lot more work on interferon now that they understand what the interferon is doing in our body. So for people with lupus, something such as a virus triggers an immune response. It causes the interferon to produce antibodies, which then attack the body in different ways, our different organ systems. Lupus patients have a different pattern of gene expression with B and T cells than the general population. Lupus is a technically complex and aggressive dialogue between T and B cells. So other people get the flu, pneumonia, herpes, and their T and B cells don't react the way ours do. So when something like that happens to us, and our T and B cells communicate in very destructive ways. So the treatments targeting these B cells, the scientists say, should be effective. What they believe now is that they understand what's going wrong in our bodies, and they are designing ways to change the way our B cells react when we get a virus. So if they can change that gene expression and the B cell doesn't do this negative communication causing the antibodies, then we should stay healthy. That would be a cure. Scientists believe that they understand how to produce that drug, and there are a number of formulas that they've come up with that are going through trials, but as of yet, the trials have not produced results that are considered statistically significant, allowing the drug to be licensed by the regulatory authority. Only one drug has been approved in the last 60 years, and that's Benlysta. Dr. Keeling talked about Benlysta. Benlysta inhibits BLyS, which is a B-cell biomarker. So Benlysta was licensed by the FDA and in Canada, but it's not accepted that it really is a good treatment, and it's very difficult to get funding for it. It's not effective for everyone with lupus. The studies do not yet demonstrate which patients it works for and which it doesn't. That's because the trial took the general lupus population rather than people with nephritis, people with skin and arthritis, people with neuropsychiatric lupus, people with higher disease activity. And so now research is ongoing to look at Benlysta in more specific populations, breaking us down into different patient groups and finding out to determine who it works for. And if those studies can get us a statistically significant result, so showing that it's particularly effective for people with skin lupus or people with higher disease activity, then there will be more acceptance within our healthcare system to fund it. So right now, if you want to get Benlysta, the doctor has to make a very compelling argument about why it will work, because the government's approach generally is it's not that effective a drug. There was a scientist from Oklahoma who said for Benlysta to be effective, the rheumatologist should do lab work and see if you have the BLyS factor. So if you have BLyS, BLISS, it's an acronym, and I can't tell you what it's for, but if you have that, then they think there's a greater chance that Benlysta would work. And then, as Dr. Keeling said, you may get funding for it through the STED program. So It's a matter of more science understanding when the treatment, who specifically the treatment works for. The significance of Benlysta is that it has no side effects. So unlike the immune suppressants, it's not suppressing your immune system, it's not killing your cells, it's training your B cells to act in a different way. So, it's a much less toxic drug than prednisone or any of the immunosuppressant chemotherapies that you would otherwise be prescribed. So they're working on refining Benlysta more and understanding when to use it. There are 60 drugs in trial now. Clinical trials are ongoing for treatment in the general lupus population and also for lupus nephritis. There are not yet clinical trials for neuropsychiatric lupus or skin lupus. So those are not as easy to test as nephritis. Nephritis is measured by proteinuria. It's a very objective measure, be in the cup and they can tell how much protein you have. And they can tell whether a treatment is working or not, when you do a follow-up test and a follow-up test, and if your protein is decreasing, then the medication is working. It's harder to measure people with other kinds of lupus. Neuropsychiatric involves a fair amount of subjective criteria. How dizzy are you? How bad is your headache? Seizures are more clear if they're observed by other people, but neuropsychiatric is subjective. The studies show a variety of different results, and so there isn't a movement quickly to test a drug for that because the trial results will not be considered as reliable. 40% of lupus patients have lupus nephritis. And so that, I think, is going to be the area of the first big breakthrough because the trials are easier and because if the nephritis progresses, those people have life-threatening disease. Survival of patients with nephritis has increased and the need for transplants has decreased. So with the drugs that are currently available, there has been success. There are 24 trials, so of the 60 ongoing trials, 24 are recruiting lupus nephritis patients right now. Now, I think predominantly those are run through the US, and I don't know that we can participate in those, but the research that Dr. Keeling is starting, she's going to be starting having a cohort of patients and accumulating data and would be tracking the progress of your nephritis, and that data would be contributed to this international collaboration. So it is really worthwhile to participate in her cohort when that is going. The advancement in the understanding of the role of interferon is significant, and so there is hope for a successful clinical trial of a biologic for lupus nephritis. A successful trial must go through 3 phases. Dr. Keeling talked about that a bit. The second and third phase involve lupus patients, and there have been some drugs that have gone through phase 2 but not been successful and have not gone through phase 3. There is now one going through phase 3, and there were a couple spoken about in the Congress. One was mentioned by Dr. Keeling, and there was another one called Adacept that there's some hope expressed for. So there are some now where the scientists really think maybe they have the formula. These trials take time. They have to go through the 3 phases and then be accepted by the regulatory authorities. If they go through the 3 phases, then the hope is that then there's a phase 4 trial, which is to maintain remission. So if after phase 3 they show the drug is effective and we are allowed to have it, the regulatory authority approves it, and you're put on that, then the next test for the scientists is how long do you stay on it? Is the drug effective in maintaining remission as well as getting your disease under control? It is thought that one of the effects of Benlysta is that it's effective in maintaining remission. So if you're on a drug such as Cellcept for the first period until your disease is under good control, then Benlysta may be a less toxic drug that you can be on long term that holds the disease in remission, which is another goal. First goal of the treatment to get you to that point where your disease is less active or in remission, and then to hold it there. The goal of the research, beyond the initial discovery of a treatment, is precise medicine. It used to be called personalized medicine. The new term is precise medicine. But this is where you as a patient would have a full genome testing so that all of your DNA would be charted. And the scientists can look then at your DNA and design a particular treatment. The genome shows how your individual gene expression is different than anybody else's. And the goal would be then that a treatment would be prescribed for you that's particular for exactly how your genes are doing things wrong. Individual treatment is prescribed rather than treating all patients with a combination of steroids, chemo, and biologics. So Dr. Moran, the chair in Melbourne, described how computer nerds will search blood data for patients which show connections between genes. So this is really done by software. That's the theory, that it won't be as much the doctor listening to your symptoms who will come up with what is the best treatment for you. It will be the blood analysis and then a software program figuring out exactly how to retrain your genes so that you can be healthy. The path to get there, to precise medicine, requires screening of patients for biomarkers that have been identified for results, type, severity of disease activity. Patients will then be invited into trials targeting specific forms of the disease, and biologics will be tested. This is expensive, it's cumbersome, time-consuming process, but the formulas have been designed and the scientists are expecting success. The next hurdle after a treatment is approved is coverage. So a treatment is not successful if it doesn't reach the patient. Scientists can say, I've made the discovery, but if we're not getting the treatment, it's not considered a success. So Benlysta was approved, but it's not easily obtained in Alberta. I was glad to hear Dr. Keeling say that some people are getting it under the STED program, but I don't think that's a common event. U.S. scientists think that if the regulatory authorities are involved all the way through the research process, from the beginning of the clinical trial at every stage, then the approval will come more quickly once the phase 3 trial results are successful. The UK has a national policy about funding Benlysta, the only country in the world to do this yet. And they involve patients to get there. So they invited lupus patients to join a national rheumatology committee in which patients worked with medical experts to develop a policy. The policy was formulated to address the problem with coverage that existed because in the UK, many of the people with more severe disease are in immigrant minority communities and they don't have good health insurance. And so they're having more serious disease, but they have less opportunity for treatment. That was thought to be an unequitable situation. And so this committee came up with a policy which was passed by their national health care provider. The policy provides the drug will be covered as an add-on treatment. So you're already receiving Cellcept, Imuran, low-dose prednisone, and then it's added on to those for people with active autoantibody present, and only if the patient has double-stranded DNA, low complement, and a disease activity score of 10 or higher. So when Dr. Keeling alluded a bit to how in research, when you visit your rheumatologist, they'll score your disease activity. The North American and European standard is called SLE, and it was described by Dr. Petrie when we had her come to Edmonton 2 years ago. So you go into the doctor and they evaluate your arthritis, your skin, your fatigue, your headaches, your nephritis, all of the different things that are happening, and give you a disease activity score. And so if the score is 10 or higher, then that's considered in the UK, and you have these other blood elements that then you, and the other drugs are not getting your disease activity under 10, then you would get funding for Benlysta. And so in the UK, that applies across the board, no matter what private insurance you have or what community you live in. So this is the first policy in the world providing a standard for individual coverage for Benlysta and a model which could be adopted here. And so I think one of the initiatives the Lupus Society may consider in Alberta is urging the government to look at that policy and take a similar approach, so that then it wouldn't matter whether the individual has private insurance or insurance through their work. If they fit that criteria, the government would provide Benlysta. And that would be a more stable program than STED. STED works well for short-term, but it's considered a short-term drug therapy, and when you first get STED funding for your medication, there's no guarantee that it will continue. So if we had this policy and you needed Benlysta on a long-term to maintain remission, then it would be covered. Predominant theme of the Congress was the development of new treatments, and it's speculated that whoever gets there first will win the Nobel Prize. So there's a real push amongst these scientists to be the research group that gets through the successful phase 3 trial with a drug that has more impressive results than they have been able to demonstrate with Benlysta. And perhaps then there will be a Nobel and people around the world will hear about us. The international collaboration was impressive. The desire of the scientists to improve quality of life for people living with lupus was expressed through the advancement of science, rather frankly than through advice to patients about coping with lupus. There wasn't a tremendous amount of advice about new ways that we can feel better, but the real focus was on finding the cure so that, then our quality of life really is better. A rheumatologist from the Philippines said that in her clinic they find patients are most concerned with fatigue and reduced ability to work and perform physical activities. And Dr. Keeling alluded to that fatigue, headaches, this is what people come in and we're very discouraged about. But the physicians are most concerned with strokes, seizures, kidney failure. So, for us, on a day-to-day basis, we're tired, we have headaches, we feel we can't fulfill all of our roles the way we'd like to, we just can't contribute as much as we want to. But from the doctor's point of view, they're relieved when we come in and we haven't had a seizure, we don't look like we're at risk for a stroke, and the proteinuria is where it should be. So they have a different context for evaluating quality of life for us than we do. The Philippine rheumatologists, though, encourage doctors to help patients set goals so that when we go in, they say, okay, where do you want to be in 6 months and where do we want you to be in 6 months? So the goals should be shared, not just reducing protein, but also helping us with the things that really bother us on a day-to-day basis. There was some research presented on diagnostic imaging of the brain and heart to detect heart disease process or to detect cognitive impairment. It's controversial, and so this is stuff coming out of Asia. It's not done here. It's controversial, but it was interesting. We know that ongoing inflammation during the course of the disease causes long-term damage. Techniques may be developed that demonstrate this damage in different stages, giving better understanding of the insidious disease process. So you might feel all right and your disease is reasonably controlled, but there's inflammation in your body, and it may be causing long-term damage to the heart through inflammation, to other organs through inflammation, or there may be antibodies penetrating into your brain, which contribute to your cognitive impairment. Physicians may come to know more about precisely how the long-term damage occurs through this diagnostic imaging, but without a new treatment, they are left prescribing toxic immunosuppressants and chemotherapy to stop the disease process. So if you feel reasonably well, there is some inflammation going on in your body. In these new techniques for measuring, it may be demonstrated, but your rheumatologist may be loath to prescribe you high-dose prednisone or other immunosuppressants or chemotherapy to treat the disease when you're not having stroke, kidney failure, and you feel reasonably okay. So this new diagnostic imaging is a bit controversial. It's interesting. It will inform the scientists, but it won't necessarily mean that you're offered a different treatment option. The development of non-toxic treatments which could be prescribed earlier in the disease process, should improve quality of life and slow the long-term damage, which we know occurs as we live longer with the disease. So that's the research, that's the direction of the research, and I think there is hope that they are getting closer to having this biologic that will train your cells to talk differently to each other, and will be essentially a cure. We're getting there, just not there yet. So what did they say about the issues that we're concerned about? Cognitive impairment and neuropsychiatric lupus. So as Dr. Keeling spoke about, lupus fog is something that we experience, and that really is a day-to-day difficulty. Cognitive impairment was described as the ability to proceed or to process information in an efficient manner and to perform executive function, which involves memory and concentration. Dr. John Hanley in Halifax stated that it occurs in 17% of lupus patients, but the number is variable. And he showed global trials which all demonstrate increased cognitive impairment, but with a big disparity. So 6 different studies around the world, they all show different rates of cognitive impairment, but they all show cognitive impairment that's higher than the general population. Cognitive impairment is considered a symptom of neuropsychiatric lupus. Neuropsychiatric lupus is the disease classification. It includes strokes, seizures, mood disorder, acute confusional state, neuropathies, meningitis, movement disorder, dizziness, vertigo, psychosis. And a breakdown of neuropsychiatric events in people with lupus, cognitive dysfunction and acute confusional state were shown to comprise 14% of all events. And as Dr. Keeling alluded to, it's not considered as serious, so the specialists treating neuropsychiatric lupus are much more concerned with seizures, strokes, and psychosis. But they acknowledge that, that there is cognitive impairment that is caused by lupus, there is confusional state, and also mood disorder. Those things may be caused by other medications. They may also be caused by lupus. And Dr. Hanley said whether it's caused by lupus or not, this is what is bothering patients, and the rheumatologists need to treat it. Dr. Betty Diamond of the US stated that cognitive impairment and mood disorders are the most common manifestations of neuropsychiatric lupus. Her research has looked at different kinds of impairment, linking one antibody with poor spatial memory, but good object memory. She stated that some patients who seem to navigate the world may actually be experiencing severe cognitive impairment. So they have a routine, they go about their days okay. Doctors can't always detect it without doing some more testing. And she encouraged physicians to test for different kinds of cognitive function. One she described was showing a diagram to a patient, having the patient copy the diagram from looking at it, and then taking it away and having the patient do it again. So she's saying some people have more verbal issues, some people have more spatial issues, but she believes the issues are there, and the different kind of cognitive issue may relate to a particular antibody. So one for verbal, one for spatial, for different kinds of memory. And so she's doing some interesting research on that. And so she was more convinced that cognitive impairment is an issue than Dr. Hanley in Halifax was. Clearly, they don't know how to objectively study it, so different rheumatologists have different opinions, but they are thinking about it and they know that it bothers us. So it's clear that lupus fog, confusion, and mood disorder occur, and the disease mechanisms causing those symptoms are being studied. Unfortunately, there are no separate non-toxic treatments for these symptoms. So again, like the mild inflammation going on in your body that you don't really feel, neuropsychiatric stuff you feel, but the only treatments are the big guns. So if you have headaches and your memories, you're having some confusion, your memory's not that good, the rheumatologist is going to be reluctant to treat you with high-dose prednisone or immunosuppressants or chemotherapy to treat that if you're not having strokes, seizures, or organ failure. So it goes back to the research. We need we know these things are going on. The doctors know these things are going on, but we need more treatment. Another approach to headache and cognitive impairment is the antiphospholipid syndrome. So antiphospholipid syndrome is the sticky blood. It's where your blood clots. It's a factor in miscarriage. So during a pregnancy, the blood can get sticky, clotting, and then there can be a late-term miscarriage. Antiphospholipid syndrome can cause, or it would be related to headache, Raynaud's, if you have the blotchy legs, livedo reticularis, so it's a circulatory issue. And it may be the cause of the seizures and strokes. So headache and cognitive impairment can be caused by antiphospholipid syndrome, and it's diagnosed through blood work. There's a new blood test. So antiphospholipid has been understood for 20 years, but there's a lot of work being done to understand it more. And there's work done to refine the blood test. So some people who had a lot of the symptoms of antiphospholipid syndrome did not test positive in the lab test, but the lab test has now been refined so that perhaps what you have is mild antiphospholipid, and through a new breakdown they can see what's happening in your blood. So the University of Calgary's Dr. Marvin Fritzler, has a blood bank, and it's the only lab in Canada that now does a more refined test for antiphospholipid syndrome. And I discussed it with Dr. Keeling this morning. She's familiar with that test. It's called PSPT. And so you can request that your blood be sent for that test. If the doctor says, well, you don't have APS, you can ask for the PSPT test, and perhaps what you have is of less severe form. This biomarker can be discovered, and if that is there may be other treatment options. There is a doctor in London at St. Thomas's Hospital in UK, and he also works in Dubai, and he's been the major researcher in antiphospholipid syndrome for the last 20 years, and he has successfully treated people who have difficult pregnancies and keep miscarrying, and he can treat, and they're miscarrying because of the antiphospholipid syndrome, and so he treats it and delivers babies that may not, where the pregnancy might not be successful in other centers. And he uses aspirin to thin the blood, and if that isn't effective, then he'll use Coumadin to get the patient through the pregnancy. And he has theorized, if you have headache and cognitive impairment, that it may be that low-dose baby aspirin may be helpful, and if that isn't helpful, then maybe a blood thinner, heparin, might ease those symptoms. So that's a different approach than the neuropsychiatric doctors take, but it's another approach to headache and cognitive impairment. He thinks if the blood is thinned a bit, you have better circulation, your headache may improve. And he said that he'd noticed this in pregnant women, that once he put them on heparin, their headaches disappeared. So it's something that he recommends for treatment of headache, is low-dose baby aspirin. If that isn't successful, heparin. So that is an option to discuss with your doctor, in that and I was talking to Dr. Keeling about it, there are some complications from the blood thinners, but perhaps less than there would be if you were taking increased prednisone or immunosuppressants to treat those symptoms. Fatigue is our big complaint, and as Dr. Keeling said, we can exercise, diet, try to live a healthy lifestyle, but they don't really have a pill to give us to help our fatigue. It was acknowledged at the conference as a major problem, but as I said, less of a concern to the patient than to the physicians who are focused on the life-threatening issues that we may have. So physicians are reluctant to prescribe toxic drugs for our fatigue unless there's some evidence of lupus disease activity. But they do recommend that every patient take Plaquenil, which they think may help your fatigue, and vitamin D. So Plaquenil has been proven to prevent flares, improve rash and arthritis, increase survival, protect from thrombotic events, reduce cholesterol, and reduce the risk of early cumulative damage. So Dr. Petrie talked about that when she was here 2 years ago. Dr. Keeling talked about that this morning. Very important to take Plaquenil. It is safe during pregnancy. and everybody should be taking it. Many lupus patients are vitamin D deficient. This was addressed by a doctor from Manchester, and he said vitamin D. But particularly for us, because we avoid the sun, normal, healthy people absorb vitamin D from sun exposure. We hopefully are not getting exposed to the sun, so we're not getting vitamin D that way. And then for those of you who live in the most northern large city in the world, Edmonton, of course you're getting less sun. So vitamin D supplementation is really important. Dr. Keeling gave a guideline for that of 2,000 milligrams a day. That's what I take, and they really think that vitamin D is important for us. At the last World Congress I went to, in Vienna, there's a doctor, leading world expert from Israel named Yehuda Schoenfeld, and he believes vitamin D is going to cure everybody. He says he gives it to his dog. So, you can't go wrong. He said you're never going to have too much vitamin D. Take your vitamin D. And so that was echoed in Melbourne. So we were told, in terms of fatigue, take Plaquenil, take vitamin D, live as healthy a life as possible. But no new solutions for fatigue or for arthritis. There was no magic bullet for arthritis. We hope that exercise helps that. But and moving loosens up your joints, but the physicians didn't have anything new for us there. Cardiovascular disease. The risk of cardiovascular disease for lupus patients is increased by the inflammatory process of the disease, by high blood pressure, by diabetes. And so high blood pressure and diabetes often co-occur with lupus, and if you have those things, all three, your lupus, your high blood pressure, your diabetes, all increase your risk of cardiovascular disease. It really, it gets kind of obnoxious because it seems like everything we hear about says the risk is increased for people with lupus. The risk is increased. It just was an ongoing theme on, and it's kind of depressing. But what it means is that we have to be very aware that we have this increased risk and do as much as we can in our lifestyles to combat that. So steroid use increases the risk of cardiovascular disease. Sedentary lifestyle increases the risk. And, when you have arthritis and fatigue, of course, you're sedentary. It's we feel to combat the fatigue, we have to pace ourselves and rest. But for cardiovascular disease, activity helps. Body mass index is an issue. Patients with kidney involvement, so if you have nephritis from your lupus, then we know patients with kidney involvement have a higher risk of cardiovascular disease. So the Manchester researcher, Dr. Ian Bruce, he corroborated research that was it was groundbreaking research done in the U.S. by Dr. Susan Manzi, and we had her come and speak in Calgary, and she spoke to medical rounds, and that, I think, was videotaped and is available. Dr. Manzi did leading research to show that young women with lupus have 50 times the risk of heart disease of the general population. And so the UK has now done that research, and they come up with the same result. They say over half of the first cardiac events for female lupus patients occur before age 55. So that's not the normal population. The normal population of women having heart disease would be over 55. But for us, it's people under 55. If you have no symptoms of cardiovascular disease, how do you know it's developing? If you haven't had chest pain, if your blood pressure is controlled, if your ECG is normal, then your doctor may say you are not at risk for cardiovascular disease. But ultrasounds of the carotid arteries, so these arteries in the neck, in the UK and in the US, there have been ultrasounds, so non-invasive tests of these arteries of young women with lupus, and they show narrowing of the arteries and they show plaque development. So this is an ongoing process even when you feel well and your disease is not that active. Because you're at increased risk, your arteries may be getting narrower, and you don't feel that process, but then you start to have symptoms. So how do you guard against that? The UK has, they told us about this concept called Metabolic Syndrome. So it's a new way to classify somebody who's at risk, but they don't yet have the symptoms. So metabolic syndrome is a clustering of risk factors for cardiovascular disease within an individual. So the factors are high blood pressure, obesity, apple shape. So Dr. Bruce talked about, the waist circumference. So that is a factor in metabolic syndrome. So it's a predictor. It's a risk factor for heart disease. Raised triglycerides, low HDL cholesterol. HDL is the healthy cholesterol, so you want that number to be higher, not lower. If it's low, that's a concern. And insulin resistance or hypoglycemia. So the standard is that your doctor should be monitoring you for metabolic syndrome. Again, bad news, metabolic syndrome occurs at higher rates in the lupus population, higher than the general population. Metabolic syndrome is not stable, so you might have some of those factors on one visit to your doctor and then less on the next. So the doctors were told to regularly monitor lupus patients for these risk factors for metabolic syndrome. Plaquenil stabilizes metabolic syndrome. So, and then our risk of cardiovascular disease is reduced. So another reason to be taking the Plaquenil. Patients with lupus also have impaired blood vessel function. That's been demonstrated in the UK. They've looked at the blood vessels, and they find that the endothelial lining of the blood vessels in people with lupus has microparticles. So that this damage to the blood vessels is another factor in cardiovascular disease, besides the plaque and the narrowing of the arteries. But they think that if you're vitamin D deficient, then vitamin D may protect against this blood vessel damage. So another reason to take vitamin D. Hispanic and African patients and those with higher lupus disease activity have an increased risk of cardiovascular disease. Should you take statins? So statins would lower your cholesterol. Statins may be helpful once there are symptoms, but statins have not been helpful for people with lupus as a preventative measure. So there's no need to go on statins before if you are not having high cholesterol or cardiovascular symptoms. So it's not something we can do on a preventative basis. There was a researcher from China who, and she admitted her research was a bit controversial. Her group did MRIs of the hearts of lupus patients who did not yet have cardiovascular symptoms. And she used a mapping technique, so taking the images from the MRI and then a sophisticated mapping formula demonstrated inflammation is present within the heart of people with lupus who didn't yet have heart disease. So, we think it's that there is this process ongoing, but we really don't have an answer for how to prevent it other than taking the vitamin T and taking the Plaquenil and living well. So, what we were told, and Dr. Keeling, I think, alluded to a lot of this, in order to minimize your risk for cardiovascular disease, take Plaquenil, take vitamin D, do not smoke, exercise, monitor your body mass index and your waist circumference. Make sure that your doctor is doing regular monitoring of your blood pressure, regular monitoring of your lipids, your cholesterol. Cooperate with the tapering of steroids. Getting the steroid dose down reduces your risk of cardiovascular disease, and good control of the lupus. If your lupus can be well controlled, your risk is lower. So healthy living and using the things that are non-toxic that are available to us, which are the Plaquenil and vitamin D, is the most we can do at this point, and then we hope for more. Dr. Bruce, the Manchester doctor, advised physicians of the importance of regular assessment of patients for metabolic syndrome and cardiovascular risk factors, and the reduction of steroids and maintaining good disease control. So when you see your rheumatologist or your family doctor, they should be taking your blood pressure, running cholesterol tests regularly, talking about your body mass index, encouraging ways of healthy living. And even though those things might not directly relate to your lupus, they're very important to your ongoing health. Nephritis. Do we have people here with nephritis? A few? Yep. So the standard of care for nephritis was set out by a doctor from Belgium, and he gave his top 10 tips to physicians. So he's telling the physicians, this is how you need to treat patients with nephritis. He said, always do a renal biopsy to classify the type of nephritis and determine whether the antiphospholipid syndrome, the sticky blood factor, is there. And then he said he always does a second biopsy. So I think traditionally patients have been reluctant for the biopsies, but the doctors consider the biopsy really important so they understand exactly what type of nephritis you have. Then he defines a target for proteinuria decrease. So right from the onset of diagnosis, he does the biopsy and then says, okay, within 6 months, this is where we want your protein to be. And then when he tests it again in 6 months, it gives him an idea of what your disease course is going to be like. So that targeted goal is an important part of the process. He prescribes less steroids than he used to. He knows he can treat the nephritis without hitting it with huge doses of steroids at the beginning, so steroids are reduced. CellCept induction, and so CellCept is the standard around the world now. It used to be cyclophosphamide, which is more toxic, and so the induction now will be a combination of steroids and CellCept. He maintains immunosuppressants for 5 to 10 years to avoid relapse. So you may be better, your protein is reduced, you feel okay, but there is a concern that the nephritis will flare again, and so you have to stay on some form of immunosuppressant for 5 to 10 years. Although that might be from CellCept, you might be put on to rituximab, perhaps Benlysta. There may be other immunosuppressants, but there will be some agent present to keep you in remission once you get there. Prevent and treat comorbidities. So the nephrologist as well should be aware of hypertension, diabetes, cardiovascular disease, and all of those have to be in good control as well. And then this was interesting. His 7th tip was unmask non-adherence. He says some patients will not take the Plaquenil and they claim to be taking it, but they're not. So he recommends to physicians that they do blood work to see if the Plaquenil is there. So he's telling the doctors, make sure, not just what we say, but look at our blood work to verify if we are, because they believe so much in the protective value of Plaquenil. He encouraged doctors to keep the faith in targeted therapies. So you come in, they set the target, and then they might not initially happen as quickly as everyone wishes, but he said stay the course. Rituximab is used now. It has not been demonstrated in trials to be effective, but they know rituximab is effective, not for the initial inception, but then you maybe switch from CellCept to rituximab, and they believe it works. So this is what he's saying, keep the faith. Even if the research doesn't demonstrate, they are finding in clinical situations that it is working. So don't jump from course to course. Stay the course on what they believe to this point. He says to watch trials in the pipeline. There are some promising treatments in trial. And then he says keep hoping for precise medicine. This is the medicine targeted to your individual genome. He says this has worked in breast cancer. So for people, breast cancer is diagnosed very early now, and the gene analysis is done, and the treatment is targeted, and people have less chemotherapy than they used to. So he said if it can be achieved in breast cancer, it can be achieved in lupus. So that was the state of the art that we were told for nephritis. The movement from CellCept to use CellCept started in the UK and in Europe, and now North America, it's the standard, and Australia, it's the standard, and so all of the countries have moved away from cyclophosphamide, and CellCept has been a breakthrough. It's still an immunosuppressant, but it doesn't have the toxic effects of cyclophosphamide, and so that is an advance that has been beneficial for people who have nephritis. The last topic I'm going to talk about in detail is lupus and pregnancy. So in Melbourne, there were 2 excellent presentations on pregnancy, one from a Singapore doctor and a rheumatologist, and one from a scientist in Australia, from an obstetrician in Australia. And they both had the same standard of care, and I think we are close, but there are some ways maybe we're not quite the same as the approach they do in their countries. The Singapore doctor said fertility in women with lupus is comparable to the general population, so we're able to get pregnant. Our family size tends to be smaller, and that's, she thought, due to choice, that we choose not to have as large a family because of the risks. So we are informed we're having less children than perhaps our friends are. It is accepted that pregnancy increases the risk of flare. Higher disease activity is correlated with higher risk of flare. So if you have had worse disease or having worse disease, there's more likely you'll have a more serious flare in pregnancy. Pregnancy requires a management plan with a multidisciplinary team, so you will need your obstetrician, gynecologist, rheumatologist, there may be a hematologist, a nephrologist, and you need that team of specialists working together throughout the pregnancy. And they need to regularly monitor your autoantibodies and coexisting health conditions. So if you're having high blood pressure, if you have diabetes, those have to be carefully controlled through the pregnancy as well. When you're planning a pregnancy, activity must be monitored. So before you decide to conceive, your disease activity has to be looked at so that you're conceiving at the optimal time. The goal is to have well-controlled disease for 6 months prior to your conception. Pregnancy should be avoided if there has been a recent stroke, heart involvement, lung involvement, or renal failure. So recent, that's something that happened years ago, but if that's happened in the last year, there will be concerns about the timing of your pregnancy. Nephritis has to be well controlled. General risk factors such as smoking, body mass index, and your other medical problems need to be considered prior to pregnancy, and your family history and history of previous pregnancies will be looked at. The risks in pregnancy include having a smaller baby, preeclampsia, miscarriage or stillbirth, and preterm birth. So sometimes pregnancies in lupus just don't carry to the full 40 weeks, but are successful. It's important to take Plaquenil during the pregnancy. It reduces flares and improves outcomes, and it's known to be safe. Low-dose aspirin is taken to reduce the risk of miscarriage. If miscarriage has occurred in the past, the patient may be prescribed heparin as a blood thinner. Warfarin is not safe during pregnancy. Treatments for pregnancy during lupus are a balancing act. If an immunosuppressant is needed to control the disease, azathioprine Imuran is considered safer than some of the other drugs. But it will be a balancing act between your rheumatologist and gynecologist as to what medications you're given. NSAIDs, so nonsteroidal anti-inflammatory drugs, cannot be used in the 3rd trimester. You can't use those after 30 weeks. Steroids increase risk to the mother of hypertension and diabetes, and the increased risk of preterm rupture of the membrane, and they slightly increase the risk of a cleft palate to the baby. Steroids are a balancing act, so they may be given, but the dose, the health of the mother and the health of the baby have to be considered, and the doctor has to monitor your lab work very carefully in using steroids. They can say you can never have steroids during pregnancy, but it has to be very carefully monitored. There is a possibility during pregnancy that the maternal autoantibodies will penetrate the fetal sac and the baby will develop neonatal lupus. Neonatal lupus can result in the baby developing a heart block. And so this is something that can be monitored and is occurring as the fetus is developing. To monitor for heart block, what the Asia Pacific standard is to have a fetal echocardiogram, so an ultrasound of the baby's heart. Non-invasive test, and there they do it weekly from 13 weeks to 26, and then bi-weekly from 26 weeks to the rest of the pregnancy to make sure that the heart is developing in a healthy way. And if there is an issue, steroids may be used to encourage that baby's heart development. The baby may also get a skin rash from neonatal lupus. If the heart block is effectively treated, the skin rash will resolve in the first year of the baby's life. So neonatal lupus isn't a reason not to get pregnant, but your doctor should be aware of this risk and you should be regularly monitored for it through the pregnancy. Preeclampsia involves high blood pressure, protein in the urine, and involvement of other organs. and can appear to be a lupus flare, but it's actually a different condition. Aspirin in early pregnancy may be helpful in reducing the risk of preeclampsia. If preeclampsia develops, then the delivery of the baby may occur faster. So, the take-home message from the expert in Singapore for pregnancy, that all sounds kind of negative. But years ago, pregnancy was really discouraged, and it is less so now. It just has to be managed, and you have to get pregnant at the right time in the course of your disease. So the take-home message from the physician in Singapore about pregnancy was that pregnancy should be planned at a time of disease quiescence. So your disease is not that active, can be active but not flaring. Preconception assessment should be done prior to the planned pregnancy. Safe treatment options exist and should be used appropriately during pregnancy. Specific strategies may be required in the presence of specific antibodies. So as your blood work is monitored through the pregnancy, there may be different treatments. Multidisciplinary care with close monitoring is essential for good outcome. So, there are good outcomes. It's a matter of being educated and your physicians monitoring you carefully. And an interesting note from the Singapore doctor for the men, I have not heard this before. She said she doesn't have data to support it, but that they think if men are choosing to have a baby, that they should come off the difficult meds before conception. Shouldn't have data, but it's worth knowing. Okay, that's all the technical stuff, and I just want to leave you with, I think we're doing for time? We're over time, I guess we're due for lunch. Just my quick take-home message. You hear this over and over again, but these are the things that were emphasized to the patients that we all need to do. Take Plaquenil, take vitamin D, be compliant with your prescribed meds, do the research on your treatment. So the docs are very open to you going online and learning as much as you can, and they say if you learn more about the medications, you will be less afraid to take them. So do the research, wear sunscreen and protective clothing, don't smoke, monitor your body mass index and your waist circumference, live as healthy as you can. Ensure that you see your physician regularly for monitoring of your blood pressure, your lipids, diabetes, and for ongoing damage deposit. And then this is a challenge, but we know there are brilliant minds working collaboratively around the world to give us a better life. So if we can, let's relax and have confidence that they will get there and we'll celebrate. That's all I have.